Welcome to Cancer and the Wimmera live Q&A session. My name's Robin Galleen. I'm the Mayor of Horsham Rural City. Tonight, I am delighted to welcome Dr. David Speakman from the Peter Mac Cancer Centre. He's currently the Chief Medical Officer down at Peter Mac and was intimately involved in the conception, design and build of the new facility at Parkville. David is also a practicing clinician working in both the breast and melanoma and skin units, both at Peter Mac and in private practice. He has over 20 years of subspecialist experience in both of these areas. David is the chair of Breast Green Victoria's Quality and Accreditation Committee and has also sat on numerous government boards. Wimmera Cancer Centre manager Carmel O'Kane is also kindly joining us tonight. So thank you both for your time. We've got some questions to start off. We had some pre-submitted and I certainly welcome questions coming through the chat for us tonight too, please. So we'll start with the first one from Aisha. What is the most common cancer detected in people who reside in the Wimmera?
Thanks, Robin. So we're lucky the Cancer Council of Victoria have very good figures about what's going on across our state. And up in the Wimmera and Horsham, there are about 140 new cancers diagnosed every year. And the top of that list will be melanoma, or certainly a large number of melanomas, and then other skin cancers. And then next down the list would be breast cancer and prostate cancer, the two most common cancers in men and women respectively. And then as per the rest of Victoria, there are a significant number of bowel cancers, which again across both men and women is probably one of the commonest type of cancers we see around the traps. And pleasingly, all of those things we can now see, in fact, the whole gamut of changes coming along in cancer care. So for all of those cancers, there are good prevention strategies, there are good early detection strategies, there are good treatments for most people, and even when disease gets quite severe now, we've got some even more wonderful Star Trek type stuff for when stuff gets really difficult. So it's great, and I think the other important thing I'd say about that is that almost all of those cancers that we just talked about could be treated locally, or you're either down in the likes of Horsham at the Cancer Centre, the Wimmera Cancer Centre, or with Ballarat. And there's probably only a few of those people who really need to come to Melbourne, only for very subspecialised stuff. And I think that's really important because one of the things the pandemic has shown us is that we need to be providing care closer to home, because especially when people are worried about leaving their local community, we should, as a health system, be able to provide most or all of these things, in your own backyard. And I'm pleased to say that the centre down there is certainly pushing ahead with all that type of stuff. That's great. Correct.
Carmel, would you like just to give a little overview before we get too far into, how you are working with the specialists from Ballarat and from Melbourne?
Yeah, so the Wimmera Cancer Centre, even before the centre was built, has worked well with, we have specialists from Ballarat coming up every week or fortnight, but we've also done a lot of work with Peter Mac and our telehealth project with them to facilitate people not having to travel for all of their appointments. There's some things people have to travel for, and we support that. We have volunteers and all sorts of support for them, but the things they don't have to travel for, we certainly can provide at our centre. So we've got a lot of really good working relationships with all of those specialist centres.
Terrific. So are there certain types of occupations that see a higher rate of skin cancer in the Wimmera? Craig asks, for example, farmers, or are there other types of jobs?
So I think certainly anyone who is out in the sun, the biggest preventable risk factor for skin cancer of any type, so melanoma and SCCs or BCCs, those common cancers growing on your face and your arms, are directly related to UV light. And so there's no doubt that anyone who is out working on the land all the time is going to be at more risk than someone who's not. I think we've been fortunate in Victoria to get rid of solariums, probably not that big up in the Wimmera, but certainly an issue down here, and an easily preventable cause of skin cancer. But I think this really highlights this issue of prevention. When most of us probably on this webinar were children, no one told you to look after your skin. In fact, my father always used to tell me at the start of every summer to go out and get burnt so that I would be right for the rest of summer. And as it turns out, that's the very worst thing you can do, because that's really skyrocketing your risk of getting melanoma. So sunburn under 20 is the biggest single preventable factor. And so all the work done by government in schools, especially primary schools, to make sure there's plenty of shade and to make sure that you don't go out into the playground without a hat or sunscreen, embedding that in youngsters, we're now seeing actually having a major effect on the number of melanomas and other skin cancers. In Victoria, particularly in men, it's already started to plummet. It's all going down in women as well, but that's solely down to a prevention campaign. And in terms of dollars spent for lives saved, it outweighs anything else that medicine does. So much so that a lot of the programs developed in Victoria and Australia have been transplanted overseas to be used in their schools and so forth to prevent skin cancers. We're unlucky that melanoma is so common in Australia, but it's made us a world leader in how to not just treat it, but how to prevent it. And so I think as we see those lessons come up into the adults who are coming now, we'll see less skin cancers. And I think we'll also find better ways for occupational exposure to be decreased. But little doubt that being out on the land is an issue. And an issue we need to try and address. A quick plug for the Lions Clubs of Australia, who are actually running a program for some years in Western Australia, try and increase awareness of skin cancer and provide ways for people to get checked out in regional, rural communities where there aren't dermatologists everywhere. And they're bringing that program to Victoria. Hopefully it'll start later this year, a bit like the breast screen mobile van goes around. It'll be a mobile sort of van to highlight skin cancer awareness and skin checking with a team of people who'll be able to help you learn and educate you a bit around that. So it's a great community program and really designed for people in regional and rural areas where those specialists just aren't around. But we've been lucky to have a few of the people who are going to be doing this in doing some training at Peter Mac, both in Melbourne, but also up in Bendigo. And so that's creating a great workforce, if you like, of the community to help look after the community.
Oh, terrific. Well, following on, Maureen has asked, is the Wimmera region worse than others for skin cancer cases? And if so, why?
Yeah, I think that's probably the same answer to the last question, in that it's all that exposure, that time in the sun and time on the land. And so we know that definitely a higher rate of melanoma up there than compared to other regions, or certainly to the city. And then the important stat that disappears a lot is that non-melanoma skin cancers, so that's SCC or squamous cell cancers, or BCCs, basal cell cancers, which are the most common type of cancer there is at all anywhere in the world. So those are those sort of barnacles you get on the back of your hands, up your arms, on your face, which generally don't spread to other organs of your body, but certainly can cause major problems where they are. If it's in the wrong place on your face or gets into a nerve, as they like to do, they can be very painful, disfiguring, and very hard for people to live with. And interestingly, we don't count stats on those cancers at all, because there are so many. And I think it's a bit of a hidden issue in Australia that there are so many of these cancers and so many groups of people treat them that sometimes we don't always get the best possible care we could for those people. And that's another challenge for the health system about how we improve that care. Because even though these things are a bit more basic, they're still very important if you're the person whose skin it's on or whose face it's on. But yeah, very, very big issue up there.
Well, the next couple of questions are about freckles and moles. So the first one's from Hannah. Are there certain characteristics of freckles or moles that I should keep an eye out for? And the second part of her question is, how often should I get my skin checked?
Great question, Hannah, and really something where you can actually do a lot to help yourself. So there's an easy way to remember about moles that we're looking at, where we're worried, and that's called A, B, C, D. So A is for something that's asymmetric. So that's if you just drew a line in the middle of it, look different on both halves. That's something you should go to your GP about. B is for border. So if the edge of your mole looks like the coast of Sweden, or Finland with little crevices and cracks all over the place, that's something you should go and get checked rather than a nice smooth edge. A, B, C is for colour. So if there are a lot of different colours in your mole or it's changing colour, this is a sign that you should go and get it checked. And the last one, D, is for diameter. And that's easy to remember because if it's bigger than the end of your pen, then pop along to your GP and get it checked because it's one sign that it might be growing and be potentially a problem. Now, not all of those things mean you've got a melanoma. It just means they're the type of mole that your GP, your dermatologist, or any skin specialist or surgeon would want to have a look at to make sure that we took it off or took a biopsy if we needed to. And the last thing, particularly given the questions we were just having about what happens up locally in the Wimmera, is we added, when we teach young doctors or GPs or anyone who's interested about this, to our A, B, C, D, we add E. And E is for evolving or elevated. So if you've got a mole that's growing and poking out of your skin and that seems to be changing, get along and get it looked at. One other big important plug around that to Hannah's question is that here's a great statistic. Wives are 7 times more likely to diagnose melanomas than husbands, certainly, but even more than GPs and doctors. And that's because they're very good at the devil's in the detail, at knowing when something's changing and saying to their husband, partner or kids or anyone else, that doesn't look right. That didn't look like that last month or 2 months ago. And so there's a built-in way where we can actually, because the earlier we find a melanoma, the more we're able to treat it. So I think we've got great built-in systems where people can help themselves. And, I've been married for 30 years, just last week, actually.
Well done.
Yeah, well, the main thing you learn to get to that is to listen to your wife and don't ignore it. So all you chaps out there, take some good advice.
Well done. The next one's from Robbie. If there is hair growing from a mole or skin spot, does it mean there is no risk of it being dangerous?
Great question. So that's a bit when you hear about rules of thumb. So usually if a mole has a hair in it, it's probably benign, but it's not a universal rule. So if you've got a hair growing out of it, but it is asymmetric, or the border is irregular, or the colour is changing, or it's getting bigger, you should still go get it checked. But generally, if it's a nice round mole and it's got a hair growing out of it, it will be benign. Here's a good teaching case. I don't know how well it will show up here. We'll see if telehealth really works. There's a nice mole on my arm there.
Yeah.
And every time I teach medical students, I'll just be sitting there and they'll tell I'll say, you're worried about that, and they'll say, oh yes, you should biopsy that. And I say, well, that's interesting. because I've had that mole for 40 years. It's never changed. It's not getting any bigger. And guess what? You don't need to cut it off because it's not a melanoma.
So should you pull the hair out?
No, you shouldn't touch it at all. Just normal, but it is a good, as a rule of thumb, it's relatively reassuring if that's the case, and it's round and happy and all that sort of stuff.
Okay, very good. I've got a question from Susan now. I would like to hear about new treatments for skin cancer, such as immunotherapy that used by Jared Roughead, the former AFL footballer, which was very publicised while he was, taking time out of football.
Yep, very great question, and a great news story about how medicine is moving forward. So we said prevention's the best thing you can do. If you are unlucky enough to get melanoma that spreads to another part of your body, to your lungs, your liver, your brain, somewhere very important like that, in the last 10 years, there has literally been a revolution in the way we can treat that type of cancer. And Jared is a great example and I know I speak freely about his story as he was treated here, and he's very happy that we talk about it. So Jared had a melanoma that started on his lip, but then in pretty rapid succession, it spread elsewhere in his body, where surgery was not an option, nor was radiotherapy. And so he got that cancer at a time when immunotherapy had just really started to take off. And he was fortunate enough to be treated with a drug called pembrolizumab, or a PD-1 inhibitor, Pembro for short. If you get into all this, you'll hear about Pembro and Nivo, and they're the two main immunotherapy drugs around at the minute. And that drug, what that drug does is release your own immune system to attack a melanoma. So one of the tricky things about lots of cancers is they find ways to hide from the body's normal defense mechanisms. And that's the case particularly with something like melanoma. So it's managed to build a defense against your normal immune response. And the drugs take away that defense, or release the brake on your immune system, if you like. And so it lets your own immune system attack these cancers and hopefully destroy them, as in Jared's case, wipe them out completely. And so what we've seen in melanoma, where when that situation would arise before, not many people would make it past a couple of years of life. Now, over half the people who wind up in that situation are pretty much cured, or their melanoma is evaporated and kept at bay for years and years and years. The first person we treated at Peter Mac with this type of therapy was about 12 years ago now. I'm pleased to say they're going incredibly well still. And we're seeing, so what we believe we're seeing is that in a huge number of patients now, long-term survivors. Touch wood, it's forever, that's the plan. And so then the next sort of step in immunotherapy, so that's now a standard therapy for patients with advanced melanoma, and even for patients in whom it's just spread to your lymph nodes but nowhere else. We'd now be using that type of therapy on the PBS, so not in a trial, but for routine care across the board. It's generally pretty well tolerated compared to chemo. The side effects happen much less often and are much different to the sort of side effects we see with chemo. So people's quality of life is good. And back to Jared, in his case, he was able to go back to playing top-level AFL football after this type of treatment, which you couldn't say for a lot of people who'd had various types of chemotherapy along the way. Carmel, I know that you've treated people with immunotherapy up locally, which is another great thing about it. It doesn't require high-level, Peter Mac type care every time you have it. It can easily be delivered close to home, even in some cases at home, but certainly at the Wimmera Cancer Centre without any trouble at all. So a great advance.
Very good. I was just going to ask about the injections I've seen. I saw something on TV about, they put injections in and around the skin cancer. Is that a similar type thing to the immunotherapy or something completely different?
No, excellent, Robin. Oh, you we planted these questions. So
That's
it's not that common. So that's something called TVEC, TVEC, and that is using an immunotherapy approach, but directly into the lesion. So we don't use that yet for primary melanomas, for a mole that you're just getting checked. But if your disease is spreading and you're getting nodules in your skin, one way we can try and treat that is using the direct injection, which we think acts in two ways. So to kill the cancer cells that are right there at that spot, but also to induce that immune response or that immune reaction from your own immune system again, but without having ongoing intravenous infusion every 4 weeks, which is the commonest way to get standard immunotherapy we were just talking about. That's still, to be fair, pretty experimental. And that is the type of thing, because TVEC, you don't want to have TVEC lying around. It's a live virus. So that is the type of thing that is in tertiary or centres like Peter Mac at the minute. Might come out in the future. Just want to touch on while we're talking about that, the role of clinical trials and how traditionally, if we put you on a clinical trial at a place like Peter Mac and you're in Horsham, it meant many hours of travel. And even though, like the other way around, we provide accommodation and that type of thing up here, it's not the same as being treated at home. And I think teletrials, so doing trials by telehealth, that's really starting to take off. Again, another area where Australia is leading the way. There's unfortunately a medical oncologist in Townsville who's not well known enough. His name's Sabe Sabison, but he has driven getting teletrials across Australia out throughout the medical community. And to be honest, he won't mind me saying this, almost single-handedly has driven this change in practice, which means that if you are in Horsham, there's now a lot of trials you can get on without coming to Melbourne. And that means better relations with Horsham or any regional centres we were talking about. But that can be done, you can utilise the types of things that have come about because of COVID. So using telehealth to have a consultation with a patient and sometimes on their own or with their family, in their home. But I think also much more importantly is to have a consultation with your own GP in the room, either at their local practice or indeed with some of the team, Carmel's got at the Cancer Centre, because we can do all this remotely, or at least a lot of it. And even if to get on a trial, we cut you, maybe had to visit Melbourne once every 6 months instead of once every 2 weeks, that's an amazing thing, both for patients to be able to access cutting edge stuff like TVEC injections, but also to be able to do it close to home. Because that, I think the other thing about telehealth that I haven't seen pushed nearly enough is telehealth's a two-way street. It's not just about the city telling everyone down in the country, this is how we do stuff and we can help. There's an amazing learning opportunity for physicians in the city to just really appreciate what local practitioners, what local services have to offer, and how we don't have to do everything in the big smoke. And that in fact, there are a lot of great ideas and great programs that arise out in regional or rural centres because needs must. And so the way they approach problems is totally different. And I think there's really a lot for us to learn in major centres, major city centres, about how things can be done differently. I'm sure Carmel's got examples of that. But,
I was just going to ask Carmel if she'd like to jump in there and contribute.
Yeah, thank you, and thank you, David. Yes, that's a lot of the work we already do is shared care with people from wherever it is they need to go. We can facilitate the consultations and the care at Horsham, but they can still get that specialist input from places wherever it may be, whether it be Peter Mac or the Austin or Ballarat, wherever it is. It's a work we do a lot and that we're very proud of. I think we did in 1 year, we saved patients 4 trips around Australia simply by our telehealth work that we do here at Horsham. So we've been doing it pre-COVID and have clearly increased it since COVID. So it's some work that we're very proud of because it makes a difference to our people, our community.
Are there private facilities within the centre where you can have those consultations? You don't want to be sitting out in the treatment room, obviously. So do you want to talk a little bit about the cancer centre? Because I'm sure, unless you've had need to be, you won't have been there.
Yeah, absolutely. So we have 9 chemotherapy chairs and 3 private treating rooms, but we also have 2 private consulting rooms. And those consulting rooms have very large TV-sized screens on the walls for us to do our telehealth with. So you get a really good big TV-like, Oprah-like picture of your doctors when you consult with them. So you can really...
That can be a bit scary, Carmel.
But the patients love it. They love seeing themselves on the screen as well. And we always have a nurse sitting in with them when they have their consults, so that we sit behind the scenes, we can listen to what's going on, and we can help them with whatever instructions they've been given by their oncologist or their hematologist or whoever they're consulting.
Oh, I think she's frozen.
We understand what's being said and help them. Oh.
No, you're going again.
Did you get all of that?
Yes, I think we did. Thank you, Carmel. I think that's the most important thing for those watching, that the access to the specialist locally and the access to treatment locally is just first class, and we're certainly very, very lucky to have that. I've got a question from Penny. Thanks for the presentation, David. You talked about the positive outcome of students being sun smart. Has there been a downside to reduce exposure to vitamin D in other areas of our health?
That's a great question and frequently comes up. And I think there's 2 aspects to that. One is that the downside of getting a melanoma is pretty significant. So it is a cancer with a terrible reputation, still, for a good reason, because it divides and grows very rapidly, and that means the chance that it can spread elsewhere very rapidly is very high. And so the vitamin D argument's got to be balanced up again. What is the downside of a low vitamin D? And I think there's a lot of people who are looking at the cause and effect of vitamin D, and I think it's not even in medicine, we're not quite sure about it. So much so that if you've actually had a vitamin D test with your GP lately, you might notice that the reference range, so what's abnormal and normal, has actually changed considerably. And so levels that we previously considered low are now considered normal. And so probably there's a lot of people on vitamin D supplementation where it's not necessary. So I think the message about that is, if it only takes 5 or 10 minutes of sunlight a day, usually in a country like Australia, and certainly out in a country region, to let your body metabolize or convert enough vitamin D. So there are really relatively few people who are actually vitamin D deficient, and the testing of that, as I said, is now much better, and it's much easier to address that, with a bit of vitamin D supplementation than than risking getting a sunburn. So I think, should we heed that, relatively speaking, preventing sunburn and staying out of the sun in a sensible manner, which is really what Sun Smart's all about. It's not never go in the sun. It's about, particularly in the heat of the day, We have all sorts of ratings now for sun protection, but we know in Australia that roughly between 10 a.m. and 4 p.m., 5 p.m., that's the worst time to be out. But getting a bit of your daily dose of sunlight between 7 a.m. and 9 p.m. or later at night, you're much less likely to put yourself at risk of skin cancer, but you'll get plenty of sun to keep your vitamin D where we need it.
Thank you. We could sit here for another hour or so, I reckon, but I think our time's up. So I would really like to thank you, David and Carmel, for joining us tonight and providing this insight into cancer and the options for treating that in the Wimmera. And I'd also like to thank those the participants, the community members who've sat and watched this, and we're getting thank yous from people who have sat at home and watched. And this will be recorded. It has been recorded and will be placed up on the council Facebook page very soon. So thank you both very much, and maybe we might do this another time on a slightly different topic. So thank you very much.
My pleasure. Thank you. And look after that Wimmera Cancer Centre, please. Yeah, it's a great place. They do a great job. So.
You're very welcome. Thank you. And if anyone wants to contact me with any other questions, more than welcome at any time.
Terrific. Thank you very much. Righto, we'll talk again. Thank you. Bye.